yet you should probably do both. The other thing that you probably need to know is that there's no proven benefit from imaging the small bowel if an idiopathic cause is unknown. And so the studies that have been done, they said, okay, we have an iron deficient patient. We don't know where the blood loss is coming from based on examination. We do an EGD and a colonoscopy, and those really don't show us a good source of blood loss. Do we follow this up by doing a push enteroscopy and looking at the small bowel, doing a small bowel series? And in those patients that they looked at, none of them had small bowel problems that they could find. And so it's not suggested that you need to work up the small bowel to look for a site of bleeding, again, in a completely asymptomatic patient. So anemia of chronic disease. Now this is associated with infection, inflammation, neoplasia, or CHF. This is a fairly new concept. In fact, probably not in many of your hospitals, they're probably not treating severe CHF patients with erythropoietin. And again, I think you're going to see this more and more as the years go on. Now, you distinguish anemia of chronic disease from the anemia of renal failure. Remember, anemia of renal failure, there is an absolute decrease in the erythropoietin level, whereas in anemia of chronic disease, that's not true. Most cases of anemia of chronic disease are actually not microcytic, they're normocytic, but we always group them in the microcytic category because we've done that for years and years. The mechanism includes a decrease in red cell survival, impaired erythropoietin production, but not to the level that you see in renal failure. Impaired marrow response to erythropoietin, impaired mobilization of iron. So there's a lot of factors that are involved in anemia of chronic disease, and most of those are cytokine regulated. And the way you treat anemia of chronic disease is you treat the underlying disease. If I gave you a patient with osteomyelitis or tuberculosis and they give you the CBC and there's an anemia there, and they give you the iron studies and everything is a little low and the ferritin may be normal, what is the best way to treat this patient's anemia? And the answer is antibiotics. You treat the disease and then you will treat the anemia, and the anemia will correct. Now, what's the problem with that? Well, in a lot of these conditions, like in inflammatory conditions like rheumatoid arthritis, Wegener's granulomatosis, other rheumatologic diseases, in cancers, in HIV, it doesn't work that way. You can't just treat it and the anemia gets better. So erythropoietin has been shown to increase the hemoglobin and improve quality of life in a lot of those patients. Now, the newer thing that I talked about, in patients with congestive heart failure, you may actually see an improvement in cardiac function if you treat their anemia with erythropoietin. And again, this is not something that you're going to get tested on, but it's something to think about. There's only been a few small studies that have been done looking at erythropoietin in CHF patients with low hematocrit. Sideroblastic anemia is characterized by ring sideroblasts in the marrow and impaired heme production. So what happens when you're impairing the production of heme? Well, your body's going to say, hey, I need to make more heme and I need to get more iron. You increase the GI absorption of iron, and so you see increased iron levels and not the decreased iron levels that you see with iron deficiency anemia. The hereditary forms usually present in childhood. The acquired forms are what you usually see is myelodysplastic syndrome, refractory anemia with ring sideroblasts, and you see it with drugs like chloramphenicol, INH, and lead and ethanol. Some of these forms will respond to vitamin B6 or pyridoxine therapy. So normocytic anemia, there's a few things on the differentials. The first is aplastic anemia, again usually presenting as a pancytopenia. Red cell aplasia, anemia of renal failure, anemia of chronic disease, myelodysplastic syndrome, multiple myeloma, and thyroid disease. Aplastic anemia is characterized by pancytopenia and a hypocellular marrow. Most cases are idiopathic but can be associated with chemicals, infections like hepatitis and EBV, drugs, or radiation. Now, you support these patients with transfusions, and the treatment of choice is bone marrow transplant if you have a matched donor. If you don't, then the treatment is antithymocyte globulin and with or without cyclosporin. The thing that you need to know about aplastic anemia is that there is a risk for the development of myelodysplastic syndrome, leukemia, and paroxysmal nocturnal hemoglobinuria. Myelodysplastic syndrome can present with, if you do a bone marrow on those patients, most patients will be either hypercellular or normocellular in their bone marrow. About 10% of patients are hypocellular. They do the bone marrow, it's hypocellular, and they send it off for cytogenetic analysis, and there's a cytogenetic abnormality. Then the diagnosis would be myelodysplastic syndrome. Aplastic anemia is not associated with any cytogenetic abnormalities. There are some cases of myelodysplastic syndrome that don't have cytogenetic abnormalities, and then you're basically got to pick what you want to do based on the presentation and the age group of the patient, things like that. Pure red blood cell aplasia. It's the selective absence of erythroid precursors often associated with thymoma, drugs, CLL, and collagen vascular disease. Parvovirus B19 is probably the most common cause, and in fact most cases that parvovirus that cause anemia we probably never diagnose because it's self-limited and just improves on its own in a couple of weeks. Recently, erythropoietin therapy has been implicated as a cause of pure red blood cell aplasia, and these are case reports and a series of cases in which patients who got erythropoietin developed anti-erythropoietin antibodies and ended up developing a pure red blood cell aplasia. This was really seen in the products that are used in Europe rather than Epogen and Procrit, which are used here in the U.S., but again, this is being monitored. Like I said, it's transient and self-limited in most people, and so we probably never diagnose it, but a severe aplastic crisis can develop in patients with chronic hemolytic disease like sickle cell anemia. When the aplasia is severe, you treat with IVIG and with supportive care and transfusion. Anemia of renal failure. Now, this is primarily due to, again, the diminished erythropoietin production. Okay. Anemia is present when the creatinine clearance falls below 45 milliliters per minute. These patients you do treat with erythropoietin, and what the treatment with erythropoietin has shown in patients with renal insufficiency, not with renal failure on dialysis, but just renal insufficiency, is that it may slow the progression of renal failure. And in patients who are on dialysis, it certainly increases quality of life, and it probably increases lifespan as well, and there are a few studies that suggest that. The one thing that you need to make sure in patients who are getting erythropoietin is that their iron stores are replete. Because what's going to happen when you start giving the erythropoietin in an anemic patient, they're going to use up all that iron to make blood cells, and you can actually make the patient iron deficient and cause them iron deficiency anemia by giving them the erythropoietin. So make sure that the iron stores are replete, and a lot of people will say you should treat with iron if the ferritin is even less than 100. Look out for coexisting causes of anemia, including iron deficiency, folate deficiency, and aluminum toxicity. So macrocytic anemia, we really break this down into non-megaloblastic and megaloblastic anemia, with vitamin B12 and folate really being the major causes of this. And the MCV can be very, very high. Only situations where you're going to see such a high MCV. Hypersegmented neutrophils and macrovalocytes on the peripheral smear are virtually pathognomonic. A hypersegmented neutrophil, if there's more than 5 lobes, is very, very sensitive for megaloblastic anemia. Now, remember that you can see a pancytopenia and an elevated LDH and indirect bilirubin in these patients because there is some hemolysis within the bone marrow, but it's not in the periphery, so you do not see the reticulocytosis and that you would see with a hemolytic process. So vitamin B12 deficiency. Now, most causes now we think are caused by what we call food